Well, welcome everybody. Good morning or good afternoon, depending on where you are in the country. My name is Holly Salazar. I am the CEO for the College of the College for Behavioral Health Leadership, and I want to welcome you today to this important webinar in partnership with NIAPers and Humanivations. Next slide, please. So while we are watching everybody join us here in the chat box, and before we get started, just a few housekeeping items. So first of all, everybody, this is a webinar format, so everybody will be on mute during the webinar. We do encourage engagement throughout the presentation by sharing your questions, your comments, any aha moments that you have in the chat box. So please continue to engage throughout. We will get to as many questions at the end as possible. If we don't have time to get to all, please continue to share your comments and questions and respond to one another. And we do have a follow-up webinar that we'll talk about in January, and we'll hopefully have an opportunity to address more of your questions then. If you have any technical difficulties, please just message us privately in chat, and we will do our best to resolve. The conversation will be recorded, and we'll make this available after the fact on the NIAPers and the CBHL website. And we are going to go ahead and get started here. Daniela, would you like to talk about CE?
Sure thing. Thanks, Holly. Welcome, everyone. My name is Daniela Labate-Cavalli. I'm from NIAPers. So NIAPers is really pleased that we're able to provide CE today for New York State certified peer specialists. So a couple things. In order to get that CE, we ask that you be logged into the Zoom room and not just dialed in on the telephone. And everyone who attends today's webinar will be receiving an evaluation. Of course, we welcome your feedback and we hope that you'll fill out that evaluation form. But if you want continuing education credits, it's most important that you send that back within 48 hours so that we can process your CE. Eduardo, if you want to just advance the slides a couple more, we'll get to your introduction. I'm going to turn it over to Harvey actually now to take care of that.
Thank you, Daniela, and hello, everybody. It's so great to see. I recognize a lot of people already, and there's many more that are coming in. This is a special series for me, this workshop today and the one that comes, the webinar today, in that I get to really share my friend Eduardo Vega with you. I've known Eduardo a long time. Actually, I met him at what used to be called the ACMA, the American College for Mental Health Administration, which is now the College for Behavioral Health. And as a board member of the college, I want to encourage all of you to become a member. I think Holly's trolling around for members these days, and we encourage you to sign up. It's a wonderful organization. So NIAPers, I'm Harvey Rosenthal. I'm a person in long-term mental health recovery, and for about 30 years, I've been the CEO of the New York Association of Psychiatric Rehabilitation Services, which is actually a 40-year-old organization that brings together people in recovery, people who provide services, and people in recovery who provide services to work together jointly to advance the values of recovery, rehabilitation, rights, and community inclusion. And we do spend a lot of time also on cultural competence and criminal justice reform these days, where we achieve those goals through a lot of advocacy in New York and nationally. We also do a lot of transformational training in TA, and you're welcome to contact us and learn more about that. We're in a number of states. And we created the Peer Bridger program some years ago, and we do sort of TA with other states around that. So Eduardo, I'm just going to introduce Eduardo and get out of the way here. So Eduardo, I said I met him in ACMA years ago in Santa Fe, and we have a long friendship and partnership, and I have the deepest respect for him. He's been a real pioneer in many ways, in terms of policy, in terms of groundbreaking, sort of training and technical assistance, really around the world. He's been building recovery, growth-oriented approaches to mental health and suicide prevention, driven by lived experience, human rights, and community empowerment. For over 15 years, he was the executive manager, he's involved in executive management and strategic growth in nonprofit government, including he was the CEO of Mental Health Association of San Francisco, and he was a state commissioner, and he's a Fulbright fellow. 30 years he's worked in mental health social services advocacy, including homeless services, outreach shelters. He's internationally active as a leader in mental health policy programs, advocacy, research, peer support programs, and he does a lot of training in the area of peer support and crisis counseling. So it's my great pleasure to introduce Eduardo Vega to you, and I'll turn it over to you, Eduardo.
Thank you so much, Harvey, and thanks to the College for Behavioral Health Leadership and NIAPRIS and all of you for allowing me this opportunity to present today. I'm very excited for this moment, also for working with you folks. And I want to point out, an interesting sort of connecting point. So I've been a great fan of Harvey's for years, and I've been following really a lot of the I've been following really a lot of the innovations that were led by Harvey's group, NIAPRIS, and others in the consumer empowerment and the peer support space. And an interesting point, we reference this fact that I worked in mental health and social services for 30 years, and that's true off and on. But an interesting connecting point here that I want you to keep in mind as we talk today is that, in fact, my journey working in social services and mental health came about directly as an experience, as a result of an experience of suicidal intensity that I had. I had made a suicide attempt, and I was in college. And I lost my job, and I was forced to drop out of college. And I got a job working in social services. And then first with developmentally disabled people, and then I went to move into folk rehab and then other community-based services in mental health. And that's how my journey in this field began. So off and on, I've had the opportunity to learn along the way a lot of different things. And one thing that happened with me, as an example, as a person living with a mental health condition, was that I experienced both sides of this issue of professional services and some of the less humanizing, I would say dehumanizing experiences that people have in services, as well as working as an advocate, working with people off and on. So, there's a lot of things. I don't want to talk too much about me. I just want to sort of reference that one of the things that was really interesting in my journey was that my lived experience brought me into working in mental health. It also kicked me out, because when I was in graduate school and I was working in doing an internship in New York, actually, at Beth Israel, I found that the stigma that I experienced at the hospital setting or at the inpatient setting was so much that I told myself I could never be involved with this anymore. Because I thought, I could be in this place next week. People will be talking about me this way. And that bifurcation, I think, is really interesting when we start to talk about how do we bridge lived experience, and in particularly this level of intensive services and what we call crisis services. So I do really encourage you folks to please use the chat, place as many questions as you can. I always prefer to be doing more dialogue and less kind of lecture talking. So I'm going to talk at you for a bit, but I want to make sure that we have time for questions and stuff too. So Daniela, I'm wondering if I can ask you, given our timing, to give me a heads up at 30 minutes into the hour, and then again another 10 minutes after that. Daniela or Holly, are you able to do that?
Sure, that's fine.
Thank you. Just so that I can make sure that we have the right amount of time.
You got it.
For our questions and stuff. All right. So today we're going to talk about some of these issues, like where does the classic psychiatric care model interface with mental health treatment, and sort of how does peer support, what role can peer support play in this? Now you're going to hear me use some terms here that might be new to you, and you don't have to adopt them, but they're part of my advocacy and part of the work that we're doing here at Humanivations is changing the dialogue, and that involves using some new language. So you're going to hear me talk about things like crisis support, not crisis intervention. We're going to talk about lived experience and lived expertise. Also going to hear me use the term suicidal intensity and talk about intensity as opposed to what we classically might talk about in terms of crisis or what's sometimes referred to as psychiatric crisis, et cetera. I'm going to talk a little bit about sort of the big picture here for a minute, where things sit for some of these services and these kinds of intersections at the national level. Harvey mentioned I've done some of this work internationally, but we're going to focus here today on the US. And then also really get to some place where we're going to talk about a little bit of nitty gritty. And I hope that you'll stick around. Whatever we talk about, I'm going to try to kind of do forest and trees at the same time, and a little bit of grassroots too. So this is a kind of a big challenge, but I want to let's start with like kind of looking at this kind of universe of stuff that we'll talk about. As you see here, this is kind of like the intersections of this, where this star is kind of where I want us to be focused, right? Mental health systems, crisis intervention and support, peer support, and suicide prevention. And I just want to kind of put out there that some of my experience, besides being a person with lived experience, also comes from working in community crisis settings. For many years, I worked both at acute diversion units and also in community crisis houses. So back before we had peer respite, which is now, of course, an exciting initiative in this direction. However, this picture is actually really not accurate, because this is really actually a lot more of what from my point of view, the system and the kind of world of this topic looks like right now. That's to say, mental health services and systems, big piece, intersects with crisis intervention and support a lot, which also intersects with suicide prevention and suicidology. Not exactly the same thing. And then peer support over here, resides also obviously not outside of the mental health services and systems in a lot of ways. And a lot of it here, as we talk about, and through Harvey's work with peer specialists, et cetera, within mental health services and systems. But you'll see that the intersection right here where we want that star is actually really pretty small. That's to say, based on my experience working kind of simultaneously in mental health and in the suicide prevention, suicidology world and other things, I see right now that this space is really small. And what we want to do, I hope you'll join me in this effort, is really expand that space. So this centerpiece right here, let's see if we can get it to look, more like a big chunk as we go forward. I don't want to talk too much about this sort of higher level stuff, but in case it's new for people, I want to just kind of point out that as we look at behavioral health systems and systems of care overall, this is kind of like a model that you might sort of have in mind with regard to the population, right? So the population, all people in the world would be a bigger circle. And then this sub-threshold need access kind of refers to people who aren't necessarily in ongoing recovery, aren't necessarily receiving services, but could use some supports of different sorts. Then of course we have people that are sort of experiencing ongoing recovery type services and what's sometimes called maintenance. I don't like that term so much, but recovery is a journey. Maybe somebody who's has a therapist, has some ongoing medication, but isn't kind of receiving intensive services as we would classically call it. And then down here where you see this other arrow getting closer in this intensive area where maybe folks are in a partial hospital program or are going to a program every day or have case management services and or RTF, by the way, is a residential treatment facility. These kind of intensive services, important to distinguish from crisis and acute services. So acute emergent services, I'm going to just put that in there. What we're talking about there really is things like what is now classically psychiatric emergency settings, maybe inpatient units, et cetera. And you see here's a list of the kind of things that happen at these different places. Now, right now, the way I see the picture, the green arrows reflect kind of where peer support is really active and really big. Certainly in the public sector, the big arrow over here, people who are doing well in their recovery journey, or who are well on it, so to speak, whether they're getting public services regularly or managing on their own. That's where peer support is really plugged in a lot, and peer specialist work. And then also to some degree, maybe a little bit lesser degree, in intensive programs. And I say intensive in the case of like things where people would be going every day. Now, this next picture actually shows something that looks a little bit more like what is actually happening in the world. And this actually, I developed this presentation with the World Health Organization. We were talking about subacute care and needs in the wake of COVID. But the big expectation and what we've seen, of course, is that a lot of people are living at a much higher level of stress. Now you're going to hear me talking about distress a lot, and that's a term I want to use, a normalizing term, as opposed to subacute symptoms or psychiatric lability or something like that. We don't want to use those terms. But this is the area also, this big area is where we see a real lack of services in general, and in particular where I feel like peer and mutual support can really make a difference. So as we talk about sort of the adventure of increasing this and bringing peer support and lived experience into this, helping people who are experiencing tough times, this is what sort of exists right now in terms of both people with lived experience and then actually kind of peer specialists or peer support specialists. There are folks working, obviously a lot of our peers here are working in advocacy and rights protections. A lot of important advocacy happening right there. There is a little bit, not very much, there's a little bit of peer support groups. There's some that I'll highlight when we get to that. Some folks are working, and more we're seeing peers engaged in mobile crisis and sometimes what's called joint response, where a psychiatric clinician or somebody else will go ride along with police or first responders. And then some of the other programs. Just also to highlight here, this is really just beginning where people are getting into peer support and suicide prevention support. I'm going to tell you a little bit about an exciting project that's happening in that area now. When it comes to phone and text supports, like suicide prevention hotlines and the crisis networks and crisis text lines, stuff like that, we're seeing a lot more people with lived experience get involved. I want to say, though, that the clarity around sharing lived experience within those contexts is not really there. And we're hoping that we can get there, but there's still a lot to do. So here's another way of looking at this picture. And I just want to, and this is kind of like sized for you visual thinkers like me, like, in terms of like where I see from my perspective, individuals with lived experience and peer support, providing supports directly within the system. So suicide prevention, relatively small, more in mobile crisis. Definitely a lot of people with lived experience on hotlines. It's still not really clear for most of them how to positively engage their lived experience, use lived expertise, as I call it, in that context. Peer respite services, okay, so over here, great, not enough of them. We want to see a lot more of that. I think we'll all agree. And then peer support groups, actually, when it comes to things like crisis and suicide, very, very small, very few that I know around the country. So that is starting to change, though. There are a lot of challenges, and what I think it's useful for us to think about as a group is these different types of challenges. Now, I'm not trying to suggest that this is a comprehensive list, but I want to point out that, like, when we look at the systems level and people who are, making decisions at the programmatic level, whether it's hospital systems, managed care, community mental health organizations, the challenges to integrating peer support when it comes to crisis and intensity. This is a list of some of them. I put low expectations and stigma up at the top, and I want to stick to that. You can argue with me, but my experience is that on many levels, we still really experience this, which is a sense that when things get really tough, it's got to be the licensed clinicians, people with lived experience may or may not be able to sort of handle it. And then even some more so, like some questions about whether people are qualified to be engaged in those situations, right? The scope of work for peer specialists hasn't really included work in a sort of urgent care situations or crisis or at times of intensity. In most states that I have observed, it's actually really, it's not included at all. So that's something that, you know, maybe Harvey's folks could give us some recommendations around too. How do we work specifically within this peer specialist framework? There are concerns about people being, you know, and this might fall into low expectations, but it's not necessarily unrealistic, about people being activated or re-traumatized when it comes to circumstances where they're seeing a peer maybe, you know, in handcuffs, or seeing, you know, sort of an intervention happen that feels coercive. Obviously, some of us who have experienced that thing, we don't really want to see that. So, but whether or not that's realistic, a real sort of barrier is an issue. There's limited practice evidence. I'd say we don't really have enough research on this topic. I'm going to talk about some that's developed, but although a lot of people, and I see Bevan Croft here signed up, always excited for contributions there. We haven't seen a lot of research done specifically on the use of peer support in crisis and emergency, or emergent scenarios is what I would call them. So this uncertainty exists. Like, how do I use my lived experience in a case when things are really intense, right? Or when somebody's like completely overwhelmed with feelings, or maybe they're in the process of making an attempt on their life. How can my lived experience be used in those contexts? A lot of limited. So we need more models. Now, shifting to a second to my other head as a person with lived experience and peer supporters that I worked with and that I train around the world, we do have these other really important issues with the challenges of, like, how do peer support values fit with working in these intense scenarios? If it's a, you know, there's a sort of a lockdown situation or something like that. What kind of licensing and education would people want or expect for peer supporters to be able to be involved with this? For me, most importantly, how do people feel like both competent and confident in their ability as a person with lived experience, as a peer supporter, to be involved with this? And then again, some people, and I know this personally from people talking to me, that some people have been concerned about their own experience of re-traumatization or being activated by seeing something happen or encountering somebody else's intensity. Activation is a term you'll hear us use too. Now, then there's really, I'm getting to the nitty gritty, there's this real question of, like, when it comes to things that feel coercive, what is sometimes called emergency rescue scenarios in the suicide prevention world. Like, do I, as a person with lived experience, do I want to be involved in that? Like maybe taking somebody's freedom away through an intervention, or that's the way that I would see it. So this, even the kind of role of a gatekeeper, as to say somebody who has power over somebody's access to a service or a setting, whether or not they want it, that's a real philosophical dilemma for us. Now, I want to point out that from my perspective, these emergency scenarios where somebody's life is in imminent risk are a very small portion of what we need to support people around when it comes to crisis and intensity. Very, very small portion. However, the fears around that and the risk aversion and the taboo associated with some of that stuff, certainly at the systemic level, is really big. And particularly when it comes to thoughts of death or suicide experiences. The other thing that I think is a real challenge, and that I want to talk about more, is like really a lack of specialized training. And as somebody who worked and encountered a lot of situations, I've been threatened with knives and guns. I've had people locked down and barricaded in rooms. I've met people on bridges and they're gonna jump and stuff like that. I'll tell you, like that stuff is not easy, but you can be trained in it. You can learn and you can develop the skills and the confidence. I believe personally, anybody can do that. I don't think that that's something that resides only with professionals. And I think that peers actually have a very distinctive role in this, particularly, and now we're going to zero in on the suicide type, particularly when it comes to this, right? So here's a fun meme. Hopefully you've seen this one, but I love just this imagery of, like, for those of you who might be listening, there's somebody like dodging these lasers, and the quote is, "Trying to be honest with my therapist, but not so honest that I get involuntarily hospitalized." Well, around the US, around the world, there is this real dilemma that people experience, right? Which is like, even if you have a service provider, you don't know how they might react. If you talk about your suicidal intensity, if you talk about having thoughts of death, that could activate them or put them in a position where they feel that they have to do something without your partnership. And so what would happen to me as a community counselor at one point is that they would say, okay, if somebody says this, right away, you got to stop the conversation. You got to go to your supervisor and tell them so-and-so is having suicidal ideation. What do we do? And then all sorts of things happen. So guess what? In a mental health setting, that's kind of a bummer, right? Because from my perspective, thoughts of death and despair, or when people are despairing, are not that unusual. And if you're having long-term problems with living, as some people call it, and you can't talk about them with your mental health counselors or something like that, then who can you talk about? Well, I would suggest peers can play a really significant role in here. So I want to back up just a second. I'm not going to talk too much about this slide, but just to say that, one of the ways that we can really change this dialogue is by really reframing the way that we talk about and think about what is classically called crisis in the mental health world. Because crisis, emotional, technical, otherwise, in a lot of cases really is the seed of growth. We know this, not just, people like some of us on this call who have been through some hard times and grown through them, but through literature, all of our stories about heroism and stuff like this. This is a picture of the redwood seed, and people probably know the giant sequoia. Redwood is the largest living thing on the planet, and it grows from this seed, which only opens in the case of a forest fire. So forest fires sometimes damage these trees, actually quite a lot. But the point is that for redwoods to grow, they still need to experience this intensity, and this is just kind of a model. So if we're able to rest for a second on this concept, that maybe part of the problem is even the word crisis, or the way we think about crisis, as being something inherently negative, something that you've got to end or get through right away. If we take that off the table for a minute and start to look at the role that intense times, including, I would suggest, encounters with suicidal intensity, the roles that play in people's growth, then we can start to enter into what feels more like a recovery-oriented, and I would say growth recovery-oriented discussion about not only the experience, but how we can be truly supportive, how people with lived experience and how peer supporters can really bring a unique contribution to this. So, little headline here, probably up to about 50 million people consider suicide every year in the US. About 5% of people actually make an attempt on their life, and of those, about 10% die. The point is, there are a lot of people out there who have lived with an experience of suicidal intensity, who it's been a part of their reality. as we see here, people with lived experience of suicide, and this is just like a little bit of comparison. Look how many people experience suicide thoughts or even make plans. Quite a lot of people. This is an age group. The point is, for many years, it was just not okay to ever talk about that stuff with anybody. And you don't know how your family's going to react. You don't know how, what a friend might say. You don't know how certainly like a clinician or a boss might respond to that. If you tell them, my life right now is so terrible that I'm thinking of ending it. People couldn't talk about that stuff. But if we look at this, we see that, again, a very small percentage of people actually, die by suicide, of even the people that make attempts. So the point is that many people have a lived experience of suicide, and people who experience psychological distress, a good portion of them also have thoughts of suicide and thoughts of death, but relatively few people actually go on to make an attempt. So, as a culture, we're afraid of death. And historically, the voice of lived experience around suicides has been very marginalized. This started to change about 15 years ago. Again, I don't want to get too much into this, but I hope you'll consider looking for this resource. Shortly after the beginning of the National Action Alliance for Suicide Prevention, I was involved with some folks in putting together a national group, the first ever, as far as we know, national task force of suicide attempt survivors, to talk about the experiences they had and recommendations they might have for changing the system so that people who are experiencing suicidal intensity get a different kind of care, have more positive experiences, and feel really truly supported in this process. If you look at this document, you'll see that there's a lot of recommendations here programmatically and in policy as well. This document is called The Way Forward, Pathways to Hope, Recovery, and Wellness with Insights from Lived Experience. And, I know a lot of people here, are really grounded in recovery understandings. I think that you'll see in this document a really exciting growth recovery, positive leaning framework that connects to the values of peer support. The biggest takeaway from that work that I did, and including multiple meetings with providers and people who had lived experience of suicide, was that a lot of times people at their worst moments have an experience that feels like punishment and definitely does not feel like care. There's all sorts of ways in which this works out, including, being handcuffed in the back of a police car, sometimes an experience of microaggressions in emergency rooms and this sort of thing. Point is that people want to be treated with respect when they're having their worst times. And when people are having their worst moments, I think that's when we need to be bringing a different level of compassion, more and better compassion. And from my point of view, some of the people that can do this best are people who lived experience. So,
Eduardo, sorry to interrupt.
Yes.
So we're just about at 20 minutes before the hour, and I know you would ask for a reminder, and there's also a lot happening in the chat box. So I'm not sure if you wanted to take a break and answer some questions or sort of keep going.
That's a great idea. Is there something that you could highlight for me as a question to focus on now?
Yeah, Holly, I know you've been keeping track as well. Have you seen something that popped out at you?
Yeah, Danielle. So there were several questions that have come through. I think one that came through in particular, Eduardo, in New York State, residential crisis support is a managed care billable service that any org can provide. Some organizations may staff with all peers, some a hybrid or clinical peer. model. And this individual said that they don't see the two models as interchangeable, but knows that some counties are considering centralized intake, with the benefit being fewer bottlenecks and wait lists. But they're asking if you can provide or share what issues you might see with a centralized intake.
Okay, I'm not sure I got all of that. I think that, when it comes to sort of systems, and New York is pretty advanced in this, and sort of I would just say in a certain sense, like, hats off to some degree to Harvey and folks at NIAPRS who have been able to kind of thread this needle between truly peer-driven services, user-driven services, and a clinical system in the classic sense. So I think really the issue for me, and a lot of what my passion is right now, is not so much about the people that kind of are waiting to get through that door. If it's one door or 5 doors, whatever it is, the people that are sort of in line for services and who are signing up for them, so to speak. My interest a lot more really is in the people who, for one reason or another, aren't going to get there, don't feel like that's a place they're going to get the kind of respect and care that they want, or just plain don't have any access. That's to say, so as an example, about 50% of people who die by suicide every year do interface with a healthcare provider. About 35 to 40% interface with a mental health provider within the year before their death. But about 50% of people do not do any of that. So my big hope, and I think the really important opportunity when we start to talk about things like the 988 transformation, is building a resource of peer-driven support for people, at times of distress, that doesn't require that they have, they have Medicaid, or that they have an insurance provider here or there, or that they have access to those particular service gateways. That's probably not an answer to the question, but my 2 cents.
Eduardo, I have a point I'd like to raise. Lisa Goodale and Kelly Davis, and I've lost it on my screen, but it had to do with, here it is, that it's frustrating to see, let me get you out of the way here, how organizational policies for dealing with suicidal intensity are solely driven by legal and risk management considerations, not what will be most helpful and effective. You want to comment on that?
Yeah, no, and in fact, it's not an elephant in the room, it's the rhinoceros on the field, the way that I see it, it's because the fact is, there are a couple angles to that. So one is those fears around things like liability and that risk aversion within our systems of care, mental health systems of care, is highly exaggerated compared to the actual prosecution of liability of this sort of thing. And I've been a colleague with some people in the suicide field, including attorneys, who sort of pursue some of these cases. And the fact is that this is really an example of stigma and fear. I would suggest actually maybe taboo, kind of hiding behind the skirts of risk management, so to speak. So yes, if somebody dies, that's a really terrible thing. Yes, people will die who are receiving mental health services, sometimes by suicide, sometimes by other ways. Yes, lots of people will die by suicide who don't have any interface with our services and stuff like that, whatever we're providing. Will people turn around and sue individuals or organizations for these things? Will there be, lawsuits? Yes, in the U.S. Yeah, absolutely. We live in a litigious society. But, people sue zoos because they, beat the alligator with a stick, right? And then they got chewed up. So what I'm trying to point out here is that those fears around liability are actually, from my point of view, kind of masking a deeper level of fear and discomfort around the subject. And what we really need is people like risk management, like human resources and things like this, to be engaged with more productive discussions around the balance between really giving good support to people who are experiencing hard times, and fears around a legal issue or a prosecutor, an issue of prosecution if it's an individual provider.
Thank you, Eduardo. One other point. Just want to give a New York story to folks here that are not from New York. There's a lot of time and attention being put to crisis services in a continuum. So we're paying a lot of attention to the 988 hotline, which will be a line you can call and get a counselor, not a cop, eventually. We're paying a lot of attention to peer alternative responders to police, paying a lot of attention to peer-run crisis stabilization centers, where people can get a very harm reduction, a very welcoming, warm, not a clinical sort of reaction. We have peer crisis respite programs. So we're really trying to build a continuum that is outside of a medical lens and a control lens. So I just want to say that hopefully we can talk more about that in future webinars, but there's a lot of talk, as you know, about 988 crisis stabilization and respites.
Well, yes, and I hope also, Harvey, that you will have an opportunity to share what New York is doing in this way, because as historically, I would say you're kind of really leading the field as a state in this area. I've worked in many states and in California, which of course is very resource rich right now, but we don't have anything like the sort of systematic alternative set of resources. There's other things developing, and so I think we want to see about going in this direction, more in this direction, and it's really about that, isn't it? Really, ultimately, for me, is when I'm having a really hard time, I want to be able to talk about things that are occurring to me, whether even including thoughts of death and this sort of thing. Because that was a part of my reality for a long time, and I want to be able to talk with somebody else who's been there, and I want also, if I need or if I want like a sort of a place to go, I don't want that to feel like I'm under a sort of a psychiatric or a medical lens, where my actions are being kind of constantly evaluated in terms of whether they reflect a risk that I'll act on my suicidal thoughts, right? So all these alternatives, they are growing, and some places are leading the field. And my hope is, and I think what we can do as a community, is really look to the next level. When we start to talk about a transformed system or a crisis system, as we say, that many more of these alternative, these natural, these community-based supports that include people with lived experience, and that enable people to have open conversations about this stuff really exist. In the more general kind of psychiatric crisis or personal crisis field or sort of zone, that's definitely increasing a lot over the years. When it comes to specifically suicidal intensity, I think there's still a long way to go. And in particular, I'm going to talk a little bit about what I think some of the things are that we might do to get to the next step. Does it go? I'm going to just try to go forward here a little bit. And how much time do we have left? Daniela?
We've got about 25 minutes.
25 minutes, right? I just want to make sure I'm certain when we're ending at a quarter after the hour. Is that right?
That's correct.
Excellent. Okay. So I'm not going to talk too much about this, but I want to give you guys a little bit of a notion of some hope. one of the things that is happening right now is that we're starting to develop more of an evidence base for peer support, specifically when it comes to experiences of suicide. This project is now in a 5-year NIMH-funded study where we've worked with peer specialists to meet people inpatient in the hospital who've been admitted to a psychiatric hospital with suicidal intensity, sometimes with suicide attempts, and having the peer supporters kind of work to support them in their transition and then in the community afterwards. Now, when you look at some of this data, you can see that as an example here, the control, by the way, is kind of a treatment as usual SSA, meeting with a classic psychiatric provider in a community mental health setting. You see, there's not really a lot of difference. Peer support's really making a big difference, at least in terms of some of these things. Hopelessness as an example, another aspect in which, you see peer support really providing it kind of as much benefit as a classical sort of clinical treatment model. And that's useful in all sorts of ways. I want to highlight here a little case study because this kind of, I don't want to be cynical. I say things are changing. But this was actually really instructive to me back a few years ago when I was at the Mental Health Association of San Francisco. We were funded to do a pilot project where we put together a peer-led suicide attempt survivor support groups. They changed it later to be the Attempt Survivors Mutual Encouragement Group. That was the name that the peers in the group took for themselves. Support groups that met every week. And when we started this study, I want to point out, this was funded by the state of California through the Center for Dignity, Recovery, and Empowerment. The program was developed by a lot of experts, including some research psychologists with lived experience, suicide prevention trainers, and others. We developed it in partnership with San Francisco Suicide Prevention and the San Francisco Department of Public Health. Now, you would think, oh, that's pretty great stuff. Well, we had some very interesting thing happen when we started the program. Now, the program manager had previously been the master trainer for San Francisco Suicide Prevention and a program manager at San Francisco Suicide Prevention. She was also a person with lived experience of suicide. When we started the program, she reached out to people around the county, around the Bay Area, actually around our whole area, to promote it and invite people to send folks that they were meeting to our group. Well, the response she received and the response we received was kind of shocking. She received emails from people saying that she was irresponsible and they had lost all respect for her. Notes saying, no way in hell would they ever send somebody to something like that. People saying that they had lost, that she had lost personal credibility for them as a result of being willing to bring people who were experiencing suicidal intensity together to talk about mutual support. And people telling us what we were doing was dangerous and wrong and would lead to death. Why is this the case? Maybe some of you had experienced this other thing too. It totally took me by surprise, to be honest. I was kind of shocked that we would receive such negative reactions, not just passive, not sending people, but really overt negative reactions from stakeholders in crisis and suicide prevention. So what we have to recognize is that whether it's suicide itself, whether it's fear of death, whether it's just sort of a cultural bias, this background of taboo and fear is very real. And it means that a lot of us are not talking about it. It means that a lot of people out there are not willing to kind of invest in some of these alternatives too, or they're really afraid of them. So good news. And unfortunately, we didn't get a PI and a big RCT behind this, but our instrument for measuring people's change in these areas was based on a combination of the Beck Depression Inventory, the Hearth Hope Scale, the Columbia Suicide Severity Rating Scale, and we saw some really great changes. Increase in hopelessness, decline in the frequency of suicidal thoughts, decline in the duration of suicidal thoughts, increased ability to control suicidal thoughts. Really important if you're feeling like you're kind of losing your sense of direction. So what can we do? What can we do to change not just systems, not just services, but this bigger zeitgeist, this bigger issue around how we think about people when they're experiencing their hardest times, particularly when people are talking about or having thoughts of death or suicide. From my point of view, it's three different things we start with. We start with seeing people living with distress and despair as just like us. And most people have been there. But really seeing people, not seeing their actions, not seeing their emotions or people sort of acting out or whatever. Seeing the heart of somebody suffering. Thinking about the role that crisis and distress plays in change, right? In this personal development process. If we think about struggle and crisis differently, we can talk about it differently, and then we'll start doing different things as a community, as a society, as a world. So our program, I'm going to talk about more as a model, just so that you understand, but we're really looking at how do we live in this place where we're connecting what was classically called crisis intervention and suicide prevention with peer support in the framework, from the framework of growth, post-traumatic growth, dignity focus. Growing Through is the program that I've been doing to kind of fit this space. It really emanated from this experience that I had, where we want people to receive a different kind of support. One of the things we can do is we start talking about, and this is controversial, but I'm going to put it out there. I'm really concerned about using the word crisis. I think crisis is a confusing term. It creates its own kind of dilemmas, both for individuals and I would suggest also for services, stuff like that. When we start to talk about human experiences, we start to talk about going from discomfort to distress. What we call in our program the 5 Ds, very normal terms. I'm experiencing distress. Distress sometimes leads to an experience of disability. Like I'm so overwhelmed today, I can't get to work, or I can't get out of bed. That's an experience of disability, a disabling experience related to my emotional intensity, maybe related to my thoughts. But we don't have to we don't have to use clinical language to do this. We can talk about the experience of despair. It isn't that unusual. Many people have had that. And along with despair and distress and disability, thoughts of death come up. Thoughts of death sometimes are a way that people seek relief. It can be relieving for those of you who have been there, to have this idea, well, maybe I don't have to bear with this forever. A lot of people don't want to hear this. They don't want to hear us talking about, how suicide for some people feels like it offers relief, but it's very important. We can also talk about what we call, so those are the 5 Ds, what we call the 5 Ps. Protective factors are called in the area of suicidology. That's to say, when we talk about recovery and strengths focus, what are our prospects? What else could happen? Perseverance, how are we getting through today? So I'm going to lay these out for you. This is just like kind of my last offering for today, and then we'll get to some conversation. Things for you to think about. You can tell them I sent you, but you don't have to have any fights about it. And you certainly, I know, I just want to kind of put out there that when we think about talking about distress and disability, talking about crisis, we can talk about it in different ways, in humanizing ways. We can think of, if we see crisis as somebody going through a struggle that's key to their growth, a transformative struggle, that's significant. If instead of talking about hopelessness, we recognize that in hopelessness, what we're experiencing is the need for something else. We want something else. There's an active process there, a process in which we're seeking meaning. Maybe we don't have it, maybe we don't know even how to get to it, but that's a process. You've heard me use the word suicidal intensity. I'm glad to say that actually a lot of systems have started taking on this term, and you'll hear some leaders using this term as well. I even saw it on a Kaiser hospital website one time. I was very happy. Suicidal intensity could also be, so people have to use SI, suicidal ideation is the SI is the acronym. You can keep it, but use suicidal intensity and say, why intensity? Because this is talking about an experience. It's not talking about a clinical symptom. Suicidal ideation came out of the cognitive psychology movement. And really, I think it's very demeaning because when we talk about things like suicide, thinking about whether or not you should live, that's not nothing, right? Some people would say it's the fundamental question, like I'm having an existential debate about the value of my life, about whether I should bear with this, what I could bear, and why. That's a pretty important thing. It's not a symptom of a psychiatric condition. And it goes back to questions people have been asking, deeply personal and spiritual questions for all of history. So sometimes, oh, hang on, is that right? Okay, I think this is the wrong slide deck. Well, here's some others anyway. Let's think about, using terms like despair and anguish instead of that's supposed to be psychic. Let's talk about people expressing their intensity or their overwhelm instead of using these terms like they're manic or they're acting out, this kind of thing. Now, I've spoken with hundreds of people, and probably a lot of you have as well, who've experienced suicidal thoughts and feelings in their lives, been involved with multiple different projects where we've talked to people and listened to people. And I would suggest that 90% of people will relate to the idea that when they're thinking about taking action to end their lives, what they're really doing is seeking relief. Seeking relief from the current situation. Relief for things that feel unbearable or overwhelming, or that lead us to despair. If we use that framework, this humanizing, this very experiential framework, then we start to see how we can connect with, the experience of intensity, a desire to limit, to reduce intensity and to seek relief. The other thing that we can do is we can start to talk about the difference between that and taking lethal actions, or a case where, as an example, people on the clinical side will often say, there's an imminent risk or there's suicidal behavior. We can say, okay, well, a lethal action, or you're thinking about taking lethal action today, you're thinking about taking action to kill yourself today. That's pretty significant. That sounds like an emergency to me. That is different from having a thought or having an experience or having an overwhelming sensation of wanting to die. So when we do this, we can help people get to practices and develop confidence with having conversations around some of these hard things. This is just a little overview of our program, but I'm going to skip over that here. We have provided the advanced peer crisis support training called Going Through around the country, and you can feel free to inquire more about that. I do want to end with this note, though, which is, I think, a really powerful one for somebody who actually became one of our growth allies. My lived experience with crisis and suicide was incredibly painful. I would never give it up because it made me who I am today. And I like who I am today. when we connect to this experience of difficulty, when we bring lived experience and compassion together with skills and confidence, we can meet people in their hardest times, and we can provide something really, truly, truly valuable. So how are we going to do this? We're going to need some things to happen. We're going to talk more about these on some other things, and Harvey can help us think about these things too. But we're going to need people interested to do this work. We're going to need peer supporters who are willing to come forward, or people with lived experience. We're going to need people to feel that they're trained, they're prepared, and they're confident, both to kind of be in these places where they might be facing intensity, whether it's threats of violence or other things, and also that they're able to meaningfully use their lived experience in this way. So training is really key. That's part of the reason we developed Growing Through. We're going to need funding and systems to be invested in integration, both supporting alternatives like peer support, or peer respite, but ultimately, really investing in community-based services that connect lived experience and crisis support. And we're going to need the community support. We're going to need change happening on these levels in various ways.
So Eduardo, I want to just get a couple of things in before we have to go.
Yeah, I'm done with my talking here. So
there's a lot of comments around race, cultural diversity, your Latinx background. How do you use that? What do we need to do to make services more culturally appropriate? Could you speak about both personally and just systemically, how we better deal with race, and how do you work with that, and how should we work with that?
Well, I'm really glad to hear now and to see that people are taking rectification, really, of the history of racism and the legacy of trauma into account, and starting to really look at change management. Changing things. We're not going to fix the legacy of racism. We're not going to fix discrimination on racial and cultural background basis. But this is actually, I think, some of the power that people of lived experience bring too, is when we start to really think about community-driven supports, then people in our communities can bring their experience and can connect with leadership and with others and say, hey, this is what doesn't work for us. I have done a fair amount of this. I led several projects in California, specifically focused on actually cultural and ethnically based alternatives and recovery-based kind of programs that sort of reside within the cultural norms of communities. So as an example, as a Dominican American, there's a lot of things that I experienced as very difficult here in the US, is not very community oriented. People you can't bring your family members to the clinics, and there's this idea that so these norms around how people sort of should be, how they should show up, have to be challenged in all sorts of ways. And when it really goes, I think, to this bigger picture question of what's the role that the mental health world has in making a better world overall, right? Now we know, a lot of us, that mental health systems and services, as they were called at different times, actually made things a lot worse for a lot of people. And there's still a lot of structural stigma, that's reinforced, that either plays directly into race or disability or this sort of thing, but also into people's experience of a mental health condition, where systems work to demean and control folks who don't have power. So anyway, it's a slightly different subject, but I'm glad you brought it up. And I also want to say that I've always been very excited when I go to New York to see a lot more Latinos and folks of color, in all sorts of positions, working throughout the state to lead these efforts, because that's what we really need is people to bring that experience to leadership.
Just another quickie on this topic related. What role does historical cultural genocide, oh, it just moved and jumped here, so play in suicide prevention, generational trauma? So I guess it's just the wages of racism over generations. And
Yeah,
that's that trauma, that impact is a factor in suicide prevention or suicide.
well, I mean, that's a deep question and an important one. I would say that I think one of the things that seems pretty clear from research on the public health level, right, is that when you come from communities that have been traumatized and peoples that have been discriminated against over time, that leads to a higher level of sort of baseline activation, so people's stress levels are all automatically higher, right? When you're coming from this experience, you're automatically kind of working from a deficit compared to, people who might have had a more privileged, non-discriminating background or history. So it's going to translate across generations. And I think that's part of the issue why we see, communities of color in particular in the US and Native and Indian identified people, have experienced so much more behavioral health challenges. It's not like we're not working, people are not working from the same ground. So, and the legacy of poverty and all these other things makes it that much worse. That's why, the biggest predictor of your success in life actually is your zip code, right? It doesn't have anything to do with anything else. So the neighborhood that you're coming from and what's happening there makes a huge difference.
Eduardo, what are you going to talk about in the next session? People are asking specific questions, either how they can handle things differently or how they can help people in a different way. Do you cover that in you have a whole bunch of curriculum and you're going to be doing some for us. Could you say more about that?
Yeah, so I'm glad to. So next time, what I want to talk about really is kind of getting down to what I think is the core, the sort of the linchpin of action here, which is getting people trained so that they're confident in both bridging the peer support and our peer empowerment values with work in intense situations, including, in situations where there's a threat of violence or situations where there's, suicide maybe in process or something like that. That's what the essence of growing through, which we call, peer support for life's most difficult moments. That's the essence of that training. And I'm going to provide, the framework for some of those things, and we'll do some, actual demonstrations and stuff like that. It's really about this is the thing that we need. We need to have people who feel like they're able to bring their lived experience, really confident in their ability to encounter intensity among peers. And then systems will really, they won't be able to say, oh, people aren't getting trained or people don't know this stuff or this kind of thing, right? So because we'll be showing up as a lot of folks do now, in those tough times, bringing this unique value of lived experience in really effective ways.
If there was a way to, I don't know, I'm not technologically savvy, Holly probably is, but Holly, it's a shame we can't let these folks speak to each other because there's so many great comments. We're running out of time. Yeah. One other thing is I'm at a conference in Philly today talking about, in some ways, these issues. And I found myself saying, if we get upstream ahead of suicide and crisis, what are we going to have to deal with? Poverty, homelessness, social isolation, incarceration, in an incarceral state, and a couple of other things that are very basic. So if we really went upstream and addressed some core issues that lead people to despair, wouldn't that be even better? So that's something we're working on really around the country. And I don't have time to get into it now, but we're trying to get the people that dictate what Medicaid should pay for to pay for that, not just, medicine and days out of hospital and days to the doctor. Stay tuned for that because, getting upstream of that, homelessness and poverty really lead to despair, racism and all that stuff. So anyway, I want to give it back to Holly because we only have 2 minutes. And I personally want to thank you, Eduardo, both as a friend and colleague and for your words today. I think that I can see they're very inspiring to people.
Can I just respond to one? There's a question here about the role that my Latina, I choose Latina instead of Latinx, culture plays in my recovery. And I think this is, I don't want to talk too much about myself, but it's really important that we have people bringing their cultural experience to the fore because there's a lot of misunderstandings. And so as an example, my father was the survivor of torture. He was tortured under the dictatorship. And that living with the legacy of that in our family, created a whole different set of norms than I had sort of experienced. But also, Americans didn't really understand that. Like there's not a part of the understanding. That's just like a little example, but there's so many different ways in which the experience of culture brings both strengths and also unique kinds of challenges and understandings that are crucial to how we support people recovering.
Thanks, Eduardo. And I think just in our last minute or two here, I want to thank you also for this presentation. And there were numerous questions in the chat box that we weren't able to get to today. Harvey, thank you for starting with the questions around cultural competence and white supremacy and racism. And I think, one of the areas of focus, the most important area of focus for us at CBHL right now is on equity as a foundation of leadership. And we're developing a fellow program right now specifically to prioritize equity and anti-racism as the foundation for behavioral health system transformation.
Holly, would you take a minute to explain what the fellowship program is? Because I know it's very exciting and a real future for some of the people here.
Yeah, very, very quickly in the interest of time, we're in the development phase right now. This will be a 1-year fellow program. We'll have it completed. We have a pilot cohort that will be prepared to kick off in March of this year and will be completed by February of 2023 and ready to launch this more broadly. But the whole premise is that we're shifting our leadership focus to equity and anti-racism as the foundation for activating systems transformation. And a big part of that, of course, is thinking about who we're utilizing in our workforce, how we're prioritizing the use of peers in systems, and how we can move our system forward by thinking about the individual leader, by thinking about how we are moving toward building a community of leaders who are able to work with their own communities, and then ultimately catalyzing systems change. And so we'll have more information that comes out about that. But I would love to have future dialogues on this topic in particular, if we can work on that so we can see everybody who wants to ask questions and engage in conversation. And I know we're a little bit after time, so I'll stop right there. And Harvey or Eduardo, if you have any final thoughts, please feel free.
It's NIAPRS, Holly. We always go late. We can keep going.
Got it.
If you guys can
well,
wait.
Thank you, everybody, for joining.
You usually have good food too.
What's that?
Yeah.
You usually have good food too, but we're not getting that today.
Well, hey, look, next year, our conference where all the good food will be, Daniela knows the dates. I sometimes forget them.
Yep, our executive seminar is going to be April 26th and 27th up in the Albany Hilton.
That's not the, I think he's referring to the conference with the
right, that's September. I think it's the 21st. I'll double check.
Yeah, it's in September. Look for the announcement, but we're going to go back to being live and a great events. And of course, as Eduardo points out, great food and all the food you can eat. So we'll talk more about that. And Eduardo, we'd like to have you back at the conference again. You've been with us many times. So, okay, well, look to I gave you a sign up, and colleague, we each have lists where we could advertise Eduardo's next workshop and other workshops and webinars. So thank you so much for joining. A great partnership with Holly and the college. Please check them out. They're really, really the voice of the future for leaders. There's not a place like it in the country. So again, thank you so much for joining us, and we'll see you again soon.
Thank you, everybody.